Good morning, everyone. Bienvenidos, bienvenidas to Therapeutic Resources and Latina congregations, needs, obstacles, pastoral care, and psychological referral. I'm the Reverend Dr. Alexia Salvatierra. I am the Academic Dean of the Centro Latino and the Associate Professor of Mission and Global Transformation for Fuller. So I apologize that we don't have translation for this workshop. Somebody asked me a few minutes and I went, oh, we should have done that. But here we are. We have a banquet of wisdom and experience for you in this morning's panel. But I'm just introducing the panel to start. And I just want to start before I introduce the panel by saying that the Latina community is about 60 million right now in the United States. So you will be providing therapeutic services or ministering or whatever it is that you are called to do with Hispanics. That will happen for all of you at some point or another. And for those of you who are Hispanic, what I hope for you is that this workshop will give you a bigger picture that will both feel good in terms of validating your own experiences, but also perhaps expand beyond your immediate experience. We have people who have incredible expertise on this panel. So our three panel members, Sylvia Garcia will be our first presenter. She was born in Los Angeles, which I was too. I often say that I come from a Latin American country named Los Angeles, which I do. My grandparents came here from Mexico and from the Ukraine. Sylvia was also born in Los Angeles. She is currently the Director of Training for Fuller Psychological and Family Services. She is a licensed marriage and family therapist and also licensed to supervise. She is also a registered art therapist and a certified EMDR therapist. Yes, so she's going to kick off our panel. Our next panelist is Dr. Marisol De Jesus-Perez. She is a licensed psychologist in California and Texas. She is currently the staff psychologist serving children, adolescents, adults, and families at the Center of Integrative Counseling and Psychology in Dallas. She is certified in multiple treatment modalities, including trauma and mood disorders and severe behavioral problems. She is an ordained pastor in the Free Methodist Church. She was an associate pastor for 15 years. She's been a missionary in 2 countries in South America. She is a Fuller grad, both a master's in theology and a master's and doctorate in clinical psychology. Our third presenter, our Limar Sola, who was going to be with us today, is very sick and at the emergency room, so we're remembering her in our prayers. And we luckily had Pastor Leo Ayala step in at the last moment. We're very grateful, Leo, for you. And Leo was born in Puerto Rico. He has been a family pastor for 15 years and a lead pastor. And he has personally suffered burnout and depression and then found his way back with the help of different kinds of programs. He is currently the pastoral liaison to Caminando Juntos, which is a professional certificate offered through the Centro Latino, but also in collaboration with Urban Strategies. It is their program, and it is a certificate for pastoral well-being and for pastoral mutual support in the Hispanic community. So he will be sharing from that perspective. Each of them is going to have around 15 minutes to share, and then we're going to have some dialogue between them, and then we want to hear from all of you. So we're going to move fast to get all of that done, but we are going to start with a moment of prayer. So oremos. Dios Santo, Padre Celestial, bendito Señor y Salvador, y Espíritu de Amor. Te alabamos por tu presencia, por tu gran compasión y por la llamada de servir tu pueblo. Pedimos que este taller sea de beneficio para cada persona aquí presente, para que pueda servirte mejor. En tu santo bello nombre, nombre de Jesús. Amén. So I am going to turn you over right now to Sylvia to get us started.
So today I'm going to be talking about mental health and how it affects Latinx, Hispanic population. But I want to start off by identifying who we're talking about. Okay. And so when we're talking about Latinx, Latinos, Latinas, Hispanic, there's all these terms that we have nowadays. So I want to kind of define that because I think a lot of people don't even know what that is. So who are we talking about? Who is Latino? Who is Hispanic? Well, we're talking about a heterogeneous population with very diverse backgrounds, multi-ethnic, multicultural. We're talking about 20 countries, right? And what do they have in common and what are their differences? Well, commonalities are language. We share a lot of cultural stressors. We also share a lot of cultural values. You might hear the panel talking today about familismo and collectivism because that's very important to the Latino culture, and also religion. Differences are, country of origin. We're coming from different countries, so we might have different stories and also migration histories. We all are of different skin color. We also suffer from discrimination. There's differences in documentation status, especially when we're talking about our Latinos coming into the U.S. Different social economic statuses. Okay. So I want to talk about a little bit about the identity and culture for Hispanic and Latinx community. It's very complex, it's rich, there's a lot of history there, and obviously a trajectory to this population. So really there is not one Hispanic Latinx culture. We are all very different. And it's important to really appreciate these differences and how our community members self-identify, based on race, ethnicity, and or national origin. And so, we have those people that identify as Latino, Latina, Latin, or Latinx. They may consider themselves a Latin American ancestry, like coming from Central America, South America, or the Caribbean even, right? Since the Spanish language is typically gendered, this is why Latin and Latinx are now used to eliminate that binary choice. This is actually something recent that I learned because growing up, it was like you're Latino, you're Hispanic, that was it, okay? And so those who identify as Hispanic, may be referring to ancestors from Spain or other Spanish-speaking countries. And, our cultural identity is really constructed and shared by these different groups. And even as you're talking to people coming in, recent immigrants, they might identify themselves as their country of origin instead of Hispanic or Latinx. So like if you're coming from El Salvador, saying Salvadorian. If you're from the Dominican Republic, I'm Dominican, right? So things like these. So while these terms are used interchangeably, they do have different meanings for different people. So Hispanic usually refers to individuals who are Spanish speaking or have a background in a Spanish speaking country. Latino usually refers to those who are from or have a background in a Latin American country. And of course, these encompass, like I said, culture, ethnicity, and identity, and are rooted in shared cultures and just not racial categories. So really you want to be careful when you're using these terms, right? When you're referring to a specific person and really respect their preference. So how do we know when to use which term? We don't want to make assumptions, right? And so a lot of the times, it's not helpful to label people. And even though the person across from you might look like you, they might not identify the same way. Okay. So you might want to ask them, how do they identify? Hispanic, Latino, Latina, Latinx, like I said, maybe by their country of origin. You know, some people, I myself identify as Mexican American because my parents are Mexican, but I was born here. Okay. And then back in the day, we had, you know, the whole Chicano thing, right? That's not even on here. Okay. Yeah. And some people might not even identify as any of these, and they might just say, well, I was born here, so I'm American. And so you really have to be careful not to put labels onto people. Okay. And let them really choose what they want to be called or how they want to identify. So I want to identify some demographic and societal issues. So I think Alexia mentioned, you know, our population is growing in the United States. So by 2060, the number of Latinx, Hispanic people in the United States is really projected to grow up to 119 million. That's almost 30% of the population. So yes, you will run into us, right? And having to work with us in different aspects here. 62% of the US Latinx Hispanic people have a Mexican background. Then we have almost 10% Puerto Rican background, almost 4% Salvadorian, almost 4% Cuban, 3.5 Dominican, 2.5 Guatemalan, and 33% of US immigrants are Latinx, Hispanic, and 79% of them are living in the US and are citizens. Okay. And yes, we are educated. We're getting better at this. 16% of Latinx Hispanic people have a bachelor's degree or higher. And also 19% of those people also live in poverty. Where are we more concentrated in the US? Well, there are 1 million or more Latinx people in Arizona, California, Colorado, Florida, Georgia, Illinois, New Jersey, New Mexico, New York, and Texas. So I want to get into talking about the mental health disparities in our population and just kind of give you an overview. So the next graph that I'm going to show is from the most recent census that we have. It says that 18.3% of the US population is estimated to be Latino or Hispanic. Of those, 16% are reporting having a mental illness in the past year. And that's over 10 million people. That's more than the number of people who live in New York City. That's a lot of people. Yeah. So for the Latinx community, mental health and mental illness are often stigmatized topics, as in other communities of color, okay? And this compounds the range of experiences that may lead to mental health conditions, such as immigration, which we're seeing a lot of in the news, acculturation, trauma, and generational conflicts. You know, and this might look different depending on who are we talking about here. Are we talking about our documented immigrants? Are we talking about US-born children of undocumented immigrants, right? And what does that look like for them? Are we talking about our children that are on DACA, you know, and are scared that they're going to be deported? So all these are very stressful situations. Our community faces very unique institutional and systemic barriers, and this really does impede access to mental health services and results in reduced help-seeking behaviors. The research is showing that in our population, older adults and youth are more susceptible to mental distress relating to immigration and acculturation. It's also showing the rise of, you know, the use of drugs and, you know, mental health illness, especially between the ages of 12 and 49. And serious mental illness has risen in a lot of these ages. As you can see, major depression, especially in young adults, we are seeing more people having suicidal thoughts, plans, and attempts rising, especially among our young adults. And so just, you know, just to give you an overview, binge drinking, smoking, illicit drug use, and prescription pain reliever misuse are also most frequent among this population as well. So what are some of the treatment issues? According to the APA, we are more likely to seek help for a mental health disorder from a primary care provider like our doctor than a mental health specialist. A lot of this has to do with poor communication with healthcare providers, which is often an issue, and also language is a barrier. Bilingual patients are often evaluated, and when evaluated in English versus Spanish, we are also most undertreated than the white population. So these create barriers and problems to treatment. The use of antidepressants are at the half of the rate of their white counterparts. The use of stimulants for ADD and ADHD are also half the rate. And this is mostly due to parents not believing in medication or even having being educated about how this would help, right? Or even about these diagnoses. Mental health problems can be hard to identify because we will often focus on our physical symptoms and not our psychiatric symptoms during doctor's visits. Especially in our population, we tend to be more somatic. So we might come into the doctor saying, I have all this pain in my body, but really what it is, a lot of the times, is depression, it's anxiety. So what are some of the barriers to treatment is we often experience racism and discrimination stemming from structural and systemic factors. There is a mental health stigma that really hinders this population as well, the language access issues and negative encounters with care providers. There's also a shortage of people that can provide services in Spanish or, that look like you, which also, doesn't always feel comfortable. There's a lack of culturally competent resources and providers to really meet the needs of this population. And so part of it too is immigrants are less likely to access mental health treatment. And that's because they might not have access to insurance, to healthcare. They might be scared of getting deported, right? Things like that. The attitudes among the population are, for us, religion is very important, and you're going to hear the other panelists really speak to this. It's a protective factor for this community, faith and prayer. But this can also contribute a lot of times to the stigma against mental illness and treatment, meaning we're believing that, these are demons that are causing this. It's a lack of faith, or you're just, not behaving appropriately. So really targeting religious institutions to really help encourage good mental health and treatment seeking when appropriate. There is a perception, especially among older people, that discussing problems with mental health can create embarrassment and shame for the family, which results in fewer people actually seeking treatment. So part of this stigma is, in our community, we want to keep things private. You want to keep things in the family. You don't publicly talk about what's going on in your home. They say in our community, la ropa sucia se lava en la casa, similar to don't air your dirty laundry in public. Okay. Some people do not seek treatment for mental illness out of fear of being labeled as locos, crazy, or bringing shame and unwanted attention to their families. Stigma with a community can also lead to a lack of information, as individuals may not recognize the symptoms of mental health conditions or know where to go seek help. And because mental health is not commonly or openly talked about, people seeking treatment have limited knowledge and or comfort with the different types of therapy and even medications that are available. So as providers, we need to try to be more compassionate and collaborative to engage individuals in treatment planning, really providing psychoeducation and engage them with the community resources that can help them make a good decision about what is needed for them. The other big thing, like I kind of mentioned before, is language barriers. This can cause a lot of problems where, there is a lack of understanding from the provider of what is really happening. And so, a lot of the topics that are kind of brought in are difficult to talk about and put into words, especially like if your provider does not understand where you're coming from and does not speak the same language. And so, although the Spanish is the official language in most Latin Americans, there are other places that have dialects, such as Quechua, Nahuatl, or Portuguese, right? And so, even those people have a harder time finding someone that can actually understand them and that they can talk to. Additionally, Latinx families may be bilingual or mixed language families. You know, a lot of us speak Spanglish because we were raised in a home where our parents speak Spanish, but then we go to school and we're learning English, right? And so we have parents coming in that only speak Spanish, and then we have the kids that only speak English. So it does create, you know, a lot of problems in the home. And so, you know, you want to ask also like your patients, like, what is their preferred language? You know, what do they feel comfortable in? The next thing is one of the biggest thing I think is access to services, especially with insurance. Like I said, a lot of people that we're talking about are uninsured, you know, especially if we're talking about our immigrant population. And so there is, especially in young adults with serious mental illness that do not receive treatment. And right now, nearly 90% of this population over the age of 12 with a substance use disorder does not receive treatment. There's a good mental health screening and that was done by MHA, and they really analyzed like what indicates them to seek services, and a lot of them indicated that they would either self-monitor their mental health or seek guidance from a peer, but not actually go and talk to someone. So I don't have a lot of time, but I want to go into some cultural considerations if you are working with this population. So I might go through this a little quickly, but you know, and I also want to just point out that this doesn't just apply to our Hispanic and Latino population. It could apply to other people of color as well, okay? So really being curious and having cultural humility, those are your superpowers as providers. Okay, because you ultimately want your clients to really trust working with you. And that usually takes some time to build that rapport and trust. So really being curious about how they self-identify and their prior experiences, having humility, including your positioning and your tone, and also making sure that even if that person across from you looks similar to you, not assume that they have the same lived experience as you. Okay. Safety and disclosure, acknowledging that you are part of the clinical picture, and just being aware and even kind of talking about what the differences are. So unfortunately, colorblind interventions, a lot of our clinical care and healthcare is primarily Eurocentric, which creates a problem when we're working with people of color. Parenting norms, healthy communication, intimacy, sexuality, relationship, trauma, how we express our emotions are really saturated by our white dominant standards and values. And a lot of, you know, our community does not align with those values. Lack of specified reference to race or culture really impacts treatment efficacy. So a lot of our evidence-based practice, especially in mental health, are promoting this one-size-fits-all treatment. And that doesn't really work. It really obscures the relevance of identity, privilege, power, and inclusion in treatment. So we really have to consider the lived experiences and context of the clients that we are working with. And then, of course, it misses a lot of the deep-rooted cultural and spiritual beliefs that impact mental health, right? Stigma and the reluctance and shame regarding seeking help. So I just kind of wanted to give you an overview of some things that might be helpful. So one of them is being aware of traps. So Chimamanda has a TED Talk, and it's talked about the danger of the single story. Okay, I don't know if you guys have ever heard it. All right. Yes, I see some nods. So what happens is that we tend to describe overly simplistic and sometimes false perceptions we form about individuals, groups, or populations. And this single story really creates stereotypes. And the problem with that is that they're untrue and that they're incomplete. Okay? And so when a person of privilege owns and dictates the story of another and selects what gets perpetuated and told, right? So, for example, due to the strong media coverage on Mexican immigration, we are all bought into associating all Mexicans with immigration. Yeah. Okay, so really being aware and paying attention to that. Number 2, considering cultural injuries. Really pay attention to the past, historical trauma, race-based trauma, and past experiences with providers. A lot of the people that we see are coming in with trauma that they've had with other providers, whether it be medical or mental health. Okay? And present, really being aware of your own microaggressions and current experiences of oppression. Client experience with providers who look like you. Awareness of dynamics and courage to address them. So really kind of putting it out there, like I'm not the same, you know? And I'm gonna go a little bit more into that. Number 3, utilizing cultural humility, the ability to maintain an interpersonal stance that is other-oriented or open to the other in relation to aspects of cultural identity that are most important to that person. It is not about being culturally competent, because you're never gonna achieve this. Okay, you suspend your own perspective in order really to understand and respect someone else's. So really expressing curiosity about their identity and their perspective, allowing your truth and their truth to both exist in the same space. You do not have to understand them completely. Okay. Number 4, I'm not going to go into it, but initiating the intersectional dialogue, right? Acknowledging that, hey, I am different than you. And if that's coming to be a problem, let's talk about it, okay? And for you not to really seek any approval or agreement from this person, but at least you're putting it out there, okay? Number 5, being curious about self-regulation, not just for you, but also for your clients, right? And this can look so different, right? Depending on where they're coming from and what privilege and power they have, okay? So physical, social, mental, spiritual, emotional, cultural, taking a collaborative approach with your client and providing options. Remembering that this might look different depending on your client's access to resources. Number 6, teaching and modeling responsive self-care planning. We want to teach them to actually respond and not react, right? Learning to pause, establishing accountability, awareness of the challenges and asking for help, disaster planning versus failure. So really talking out if things don't work out, and adaptation, really reminding yourself that this is temporary. We live in a world full of uncertainty. That's just the reality of it. And we just kind of have to be honest about that. And number 7, taking an active stance, really confronting oppression when it manifests through power and privilege. If you're witnessing a microaggression or you create a microaggression, really acknowledging that and apologizing. Also containing your own anxiety, discomfort, fears, and defensiveness. And really taking care of yourself as well by seeking supervision or, talking to others. Okay. I'm just going to stop there. Yeah.
Thank you so much, Sylvia, for that wonderful presentation. I'm going to bring up Marisol right now.
Okay. Good morning, everyone. It's such an honor to be part of this panel today for a topic that I'm very passionate about. And today I'm hoping to share some insights on the psychological resources and needs of the Latino community from my perspective in church leadership and also as a mental health provider. I will be sharing some of my experiences serving the Latino community through different projects that I'm being part of through Fuller and also the community mental health agency that I'm currently working for here in Dallas. I also hope to give you some insights into how the church can bridge the gap that we are currently experiencing. So understanding the resources that are already in place often give us guidance on where to start. And that's the case for most issues that we face, right? So when thinking about the psychological resources of the Latino community, I would like to present 4 of those. Number 1, family and social support. For the Latino community, strong familial and social networks are central and often serve as an emotional buffer for when the population is going through adversity. It promotes resilience. Therefore, it is important to keep in mind that it would be beneficial to help our communities have healthier families and also more cohesive communities. Number 2, faith and spirituality. Sylvia mentioned some of this already, how religion and spirituality play significant roles in the life of Latinos, and they can serve as a source of comfort, hope, and also offer coping mechanisms and social support. Therefore, when you think about this as a resource, you want to consider strengthening their ability to be connected in a faith community and also deepen their relationship with what they experience as the divine. Community-based organizations is a third resource for Latino communities. Nonprofit organizations and community-based agencies often provide culturally competent mental health services that address the needs of the Latino communities. When you heard me say that, then be thinking, how can I then help the Latino community? Well, it could be something like starting to help them get connected with these community-based organizations. I recently also learned about what a promotor de salud is, which is a community health worker in English. It's a paid or non-paid trusted member of the community who serves as bridges the government entity with the community. The community health workers deeply understand the ethnic, language, socioeconomic status, and life experiences of the community. And one of their roles is to deliver health education and support, bridging the cultural and linguistic barriers. They often provide information about mental health resources, and they provide and promote preventive care. The community workers also help individuals access the different services that the government agencies provide and help individuals navigate obstacles in accessing those services. So it's a resource that it's there. Be thinking about the resources that are in place because that is a way that we can partner. I think that important keyword for today's presentation is partnership and collaboration. And you will see in a moment how creative ways that can play out. When I think about psychological needs within the Latino community, it is important to think that understanding those needs requires a nuanced approach. Sylvia mentioned some of the factors that contribute to the mental health disparities Latinos experience with regards to access and quality of mental health care when compared to non-Latino white individuals. She mentioned the impact of acculturation stress, trauma, cultural factors such as familismo, personalismo, and respeto, which influence help-seeking behaviors, influence coping strategies and perceptions of mental health within the Latino community. With that in mind, I feel one of the needs of the Latino communities in the US is the need to be supported in their cultural identity formation. Latino individuals and families often struggle as they navigate between their cultural heritage and the dominant American culture. This process of acculturation impacts their sense of identity, belonging, self-esteem, and we can support Latino clients who experience acculturation stress that experience identity conflicts and feelings of cultural alienation by providing support as client navigates the complexities of biculturalism. Need number 2, the need to understand how familial and intergenerational issues play a role on mental health and learning to negotiate healthier relational patterns. We have to keep in mind that the importance of family cohesion and support networks for Latinos. Intergenerational conflicts, communication breakdowns, and acculturation gaps can strain those familial relationships and affect their mental health. Therefore, therapists can help recognize how Latino clients can address issues such as parenting stress, conflict resolution, and cultural adaptations within family systems to promote healthier relationships. Need number 3, the need to break free from the stigma with regards to mental health needs that prevent help-seeking behaviors. Church leaders can help with reducing the stigma surrounding mental illness within Latino communities and strive to create supportive environments where individuals feel comfortable seeking help. They might offer pastoral counseling, prayer groups, referral to mental health professionals. On the other side, therapists work to reduce mental health stigma among Latino clients by providing psychoeducation, challenging negative beliefs about therapy, and also emphasizing the importance of seeking professional help for mental health concerns. The need to be supportive in breaking down the socioeconomic barriers is another important one. Church leaders witness the impact of socioeconomic disparities, including poverty, unemployment, and lack of access to healthcare, on the mental health of Latino congregants. They might offer support services such as food pantries, financial assistance programs to address those needs. And us as therapists, we can address those systemic barriers to care by promoting advocacy and community partnerships. Finally, another need that I feel it's important to mention is the need for trauma-informed care. And when I say care, I mean pastoral care and also psychological care. Now let's talk about connecting churches or ministries with therapeutic resources. That involves bridging the gap between faith-based communities and mental health services. Therefore, this initiative recognizes the importance of addressing both the spiritual and psychological aspects of well-being. Some key points and strategies related to these are, number 1, recognize the need. Many individuals within congregations or ministries may struggle with various mental health issues such as depression, anxiety, trauma, addiction, and helping them recognize those needs is the first step in addressing them effectively. Number 2, education and awareness. Educating church leaders, volunteers, and members about mental health issues reduces the stigma and promotes understanding. Step number 3 would be building partnerships. Collaboration is key. Collaboration among mental health professionals, counselors, therapists, but also among pastors, organizations. This can expand the resources available to the community. And this can involve things like inviting a mental health expert to speak at the church, establishing a referral network, or even hosting counseling services on site. I'm rushing through this because one of my goals today is to speak about how Fuller is working on building those partnerships and how they are working to strengthen the skills of the Latino community leaders throughout Latin America. So let me go to the next point, which is training and equipping, providing training for pastors, leaders, and volunteers within the church on basic counseling skills. I'm not talking about certifying them as a professional counselor, but very often when Latino individuals struggle, us mental health professionals are not the first person they seek for help. They go to their churches, they go to their pastors. So giving them basic tools so they can listen, so they can intervene with basic support in the midst of a crisis. And also so they can understand the limits of their training and when to refer for professional services. This would be key. Number 5, establishing support groups, creating groups within the church for individuals facing similar mental health challenges can foster a sense of community and provide a safe space for sharing experiences and receiving support. 6, incorporating faith-based counseling. And 7, promoting self-care and wellness. For number 8, I have providing resources, making information about local mental health services, hotlines, and online resources ready available within the church. This can help individuals and families access the support they need. Number 9, creating a welcoming environment, fostering an atmosphere of acceptance, compassion, and non-judgment within the church can encourage individuals to seek help without the fear of stigma. And then evaluation and adaptation. Now, I would like to briefly discuss my experience partnering with Fuller in los diplomados superiores. These diplomados superiores are certificate programs specially designed to develop specific ministerial skills among Latino leaders serving throughout Latin America. These programs provide solid practical knowledge and foster community and spiritual growth for the students that comprise the cohorts. And all of this without the need to pursue a master or a doctoral program. These diplomados are aimed at anyone who serves in a leadership role within the local church, the mission field, and community work. This means that pastors, leaders supporting church ministries, church planters, or individuals involved in community transformation in their cities can benefit from these programs. How do they work? Well, this is a hybrid of asynchronous work using a very user-friendly online platform and live meetings in small groups. Every cohort ranges between 40 to 60 participants, and the small groups consist of 4 to 8 people. They also have facilitators that promote conversation and also offer practical support, guidance, and they encourage deeper reflection. Then there is a Fuller coordinator that provides guidance and support to those facilitators to make sure that the experience across the groups is similar and everybody's on track. Each diplomado consists of 6 to 7 modules, 1 module per month. And the expectation is that the students would spend 2 to 3 hours per week plus the facilitation meetings. So one of the diplomados that I had the privilege of working and collaborating with was the one in pastoral accompaniment in context of suffering and mental health care. This was in collaboration with the International Fellowship of Evangelical Students, one partner that Fuller is working with. And this advanced diploma integrates resources from theological reflection and psychology into ministerial practice. It's focused on supporting individuals who have suffered losses and traumas of various kinds. So the goal is to help the students identify the most appropriate ways to promote the holistic recovery of individuals that have gone through these adverse events. So just to give you an idea of some of the modules that were discussed in this diplomado, they cover theology of suffering, depression and anxiety, understanding grief and loss, supporting healthy family dynamics. The module that I presented was the one on key tools for accompaniment and care. And in that module, I provided tools and skills for active listening, how to create space for pain and making people feel that they can come and grieve. Also, how to, we discuss coping skills for stress and crisis response, ethical issues, when to report a case, because many pastors don't have an idea of what falls within the boundaries of their role, and also how to refer to professional resources. Another diplomado that I had the chance to serve, that I had the opportunity to serve through, is the program that it's entitled Integral Leadership of Latino Women. And this one was designed to equip women that are already serving in ministry or are considering to step into ministry to make sure that they have the tools to do it in a healthy way. The module that I was teaching focused on the path to holistic healing in life and ministry. So we work with concepts as self-esteem from a biblical perspective, recognizing trauma and its impact in the life of the minister, self-care or stewardship of the self, and disciplines that promote healing and restoration, and also boundaries in ministerial leadership. I want to be honoring of the time that we have. And I know that Leo has something very important to share along these lines, and probably something that taps into some of these programs. So I'm going to wrap it up here, but I will be more than happy during our time of questions to provide more information about how Fuller is bridging the gap, and it's working in partnership with other organizations to promote mental health and also healthy leaders that can be effective in the work that they are doing among the Latino communities.
Much, Marisol. I just want to name that our acompañamiento pastoral en contextos de trauma y sufrimiento y cuidado de la salud mental, the one that was just referenced, the first one that Marisol referenced, is starting a new cohort on May 18th. And it's for people in the US as well as people in Latin America. It's only in Spanish. But if you're interested, it's very inexpensive. Please look it up on our website. Not just for you, but maybe for somebody that you know. You do not need to have any kind of academic credential to sign up. So it's really aimed for pastors and church leaders in Hispanic congregations or any kind of Hispanic ministry context. So I'm going to give it over to Leo.
Hi, buenas tardes. Good
Other
evening.
diplomado of ours too.
Yes, I just want to say thank you for this space. And just point out that to Marisol that I just finished the certificate in mental health, and it was a blessing. So thank you very much. It's an honor. Good afternoon, everyone. My name is Leo Ayala, and I collaborate with Limar, which sadly she's not with us today, and she's the director of Caminando Juntos, and I work with her as a pastor de conexión. Caminando Juntos is an initiative of urban strategies to improve the holistic well-being and interconnectivity among pastores and pastoras Latinos. And I'm not only the pastor of conexión of that experience, but I am a pastor in recovery from burnout and depression, and mental health was a big issue for myself years ago, and I'm still recovering in a best stage right now, of course. But just to pour out that we are all wounded healers in a way, and sometimes that's exactly the beauty of this kind of opportunities that we know not only theologically, but we're talking about also this is our journey of healing. So when Caminando Juntos and the people like Limar and Danielle gather amazing group of Latino pastors, 80 of them in 2020, and ask them what are the needs of the Latino pastor, those pastors began to share more about external needs, like how to manage the church, the structure, the legal aspects, how to reach the new generation and develop new leadership, how to be a church for the second and third generation of Latinos, and many other needs. However, when the conversation continued and went deeper in that group of 80 pastors, one of them felt that there was a safe space to talk more about their own inner feelings, they start saying things like, the reality is that I feel tired and exhausted. I feel depressed. I feel like I am alone in this. And it was like a domino effect. The rest of the group then start almost exploding, saying, yo también, me too. That's the way I feel. They also express feeling of loneliness and isolation. And of course, right now we know of the correlation between burnout and loneliness. We can clearly see this in Prophet Elijah experience, as he ran into the desert just to die after a great, successful ministry. This is not different from what the pastoral population in the US is experiencing in silence. Because according to this study of Barna in 2022, 67% of the pastors are in high or medium risk of burnout. In the Latino context, we may provide in community for our pueblo, for nuestra gente, but who is taking care of the pastor, the men and women who are pastoring others, who are listening to their fears or their struggle or their trauma? And that's one of the things that for us is so important. Based on this deeper realization of what we call burnout, we create Caminando Juntos to improve the holistic well-being and interconnectivity among a diverse group of Latino pastors. One of our main strategies to address the need is by facilitating pastoral online cohorts centered on holistic well-being. So these cohorts are very diverse in representation from different denominations, genders, generation, and those pastors that they feel that they are thriving, and others that feel that they are not thriving at all. So we provide a very safe, authentic, and vulnerable space so pastors can connect with one another from a basic perspective. And in the words of one of our participants, she said, these sessions have helped me to identify some of the things that have been going on in my life and put a name on them. Now that I know what's going on, I can work on it. So we love to create this first awareness. As Marisol was saying, I think it's crucial for their journey. And let me say that for a lot of them, they need, before start to pour out, of course, their struggle, of course, they need a safe place. And that's one of the things that the pastors struggle the most, and that was my experience. I knew that there was something on me that it wasn't working right, but I just didn't know where to go, or I didn't feel safe enough to share with others. So, however, Caminando Juntos also including in this cohort of pastors that we develop with different levels of education. There are people who have PhD, master's degree, bachelor degree. And one of our participants called Giovanni, we have permission to use his example, has been a pastor for more than 10 years now of a growing and vibrant, amazing church right here in Puerto Rico, where I live. So he has been a counselor for almost the same time. Not only that, as many Latino pastors, Giovanni is bivocational, and sometimes there was a point that he has 3 jobs. And he has been also the director of multiple youth detention center right here in Puerto Rico. At the same time, he was a pastor. Of course, he was quickly moving toward burnout. So even Giovanni, as well as other pastors with PhD in counseling, theologically, and education and health, are suffering in silence, or even in an unconscious way. In Giovanni's words, in one of our sessions, he shared with us, having a doctorate in psychology, I have believed that I can treat God and my mind because I can manage stress on a conscious level and continue with a routine without stopping. However, my body and my relationship are taking their toll. And this is one of the things that we have been finding in this journey. And of course, it was my journey. Theologically, I knew as a pastor with my master's degree in theology, I know how to trust God. I know the Bible. I know how to preach. But in the process, I never stopped to make my own inner journey, the journey to deal with my childhood trauma. So what I did in the process as a man and as a pastor is covered up all up with my spirituality, my theology. but there wasn't a connection between my head and my heart. So my invitation and our invitation to consider how we are living extend to you, the people who are hearing us today, men and women, Latinos. Maybe you're a pastor, whether you are a therapist, whether you are a general pastor, whether you are a professor in theology or any expert. Like in Giovanni's situation, it was beyond his education. Perhaps he might teach some of our material from a theoretical perspective even better than me when I teach this amazing group. But Giovanni deserve a deeper process and accompaniment so he could review different areas of his life. So because of this, the Caminando Juntos program is designed to improve the holistic well-being. It goes beyond content. It's a transformational collective journey. How do we do this? Well, let me share a little bit about this amazing group of people. First, we should say that it's a diverse group. As I point first, we have 8 pastors per group. The session is very dynamic, no more than 20 minutes of content. It's a guided conversation and interaction. We also have 3 minutes at the beginning, sharing where they are, what are they processing, their struggles. It's a safe space. So they know that they are not alone, and we are not there to fix you or resolve your deep issues, but a safe place where you can pour out. And we call them also by name on purpose without all the other tags that we usually put ourselves. So every session we'll invite them to address different sanctified roots of their burnout. Let me give you an example in case of Giovanni. Once again, the space enabled him to engage and confront his own image, for example, of God in session 1 and the second session as one who is an image of a God who is bossy. That's why he told us, and demanding. An inherent theology of a God requesting him to work constantly and to suffer for the cause of that God. In Giovanni's word, this is what he said. A mí me enseñaron que tenía que gastarme para el Señor. I was taught early in my life that I had to wear myself out for the Lord, similar to what I did. I burned myself in the process. Then we move into sessions such as my identity, myself, sign of stress and anxiety, which we experience without noticing because we don't have time to stop. We are pushing, we are serving others, but we don't know how to stop just to think about ourselves. So because of this, it is very important to give that space, and not only the space, the ability and some other economical grants for them to rest, replenish, and renewal to help them disconnect. In fact, it is crucial to guide them also in finding rest because some of them don't know what to do during their time, their downtime. Even when we do the retreat that we have during the program, we need to guide them because some of them, they don't know how to stop. They haven't done that before. And some of them is the first time that they're going to take a retreat from themselves in more than 20 years. So as an example, using Giovanni, he needed time to stop, to decompress, and to listen to a God that does not use him, but one who loves him. In continuation with the rest of the process, Giovanni also needed to reconsider his ministry measure of success based on the dominant culture of more is better, which is in combination with this image of God that almost is like killing him. So you will see that after some session, now Pastor Giovanni is ready for one-on-one services. Now that the pastor is asking and open for therapy or spiritual direction. Because sometimes when they get into the program, they don't know how to embrace because of their culture, because of the way they see God or their religious context. They are not ready to receive therapy, even that. So we celebrate that also. 60% of the participants become actively involved at the end in counseling. or spiritual direction, which is a great thing for us. The sessions will continue now beyond the individual, encompass. That's the first sessions of that group. And in the second part, we move to a more collective approach of the pastoral ministry. So what we said when we talked last time with Giovanni, we told him, Giovanni, we felt that like all of you, you deserve a comprehensive process and accompaniment to consider how this theory now can go from your head to your heart and to put it in practice and allow you to adjust and otherwise this crazy agenda. In summary, this is what we hear from the participant at the end of the program. I need to give myself permission to be human again, to be Giovanni again, to be just beloved son or daughter of God, and just to enjoy the enforced rhythms of grace. Finally, at the end of this amazing journey that we did, we are in the 4th year of Caminando Juntos. Last year, we started this amazing journey with the Centro Latino, a Fuller Theological Seminary, and we developed a certificate on pastoral holistic well-being. But as we found out, it's easy to share information and to implement things, but it's the hardest process it's doing your own journey, your own work. So that's why we invite people to do the Caminando Juntos program and then move forward to work with others through the certificate of pastoral well-being. This year, we increased the capacity and sustainability of pastoral well-being of the Latino Church and of the program by designing and implementing the beautiful campaign certificate of pastoral holistic well-being in alliance with the Centro Latino. Our alumni from Caminando Juntos can continue then the journey, now learning how to accompany other pastors for the collective well-being. And you can find more information in Fuller, at Fuller. So my recommendation and our recommendation for all of us is begin this journey, processing our stories and doing our own journeys, our own work.
Wow. I promised you a banquete, and we had one, right? So we had actually designed 15 minutes between us and 15 minutes with all of you, and there was too much wonderful material. So we just, I think we're just going to go to your questions and answers. Before we launch into that, though, I did have one personal story that I wanted to share that I think really brings home some of this for our family. My daughter went away to school in a community that was not Latina, and it was her first time in her life. It was a white community in Western Massachusetts. And she was very traumatized, and she started seeing one of the counselors associated with the school. During that time, her abuela in Guatemala died, and we didn't know that she died. But the night that she died, my daughter had a spiritual experience of a visitation from her abuela that was very consoling. Her abuela was a very profound believer in the Lord and was encouraging her and saying, I'm going now to the Lord, but don't forget, I always love you. And your love, my love surrounds you. So Alina shared that with her counselor, and her counselor reported her as, having a schizophrenic tendency. So when Sylvia was talking about the bad, my daughter does not want to go to, well, for a long time she didn't. She has now applied to the MFT program because she wants to do it differently. But for a long time, she did not want anything to do with the therapeutic universe from that experience. So I just wanted to share that story. Okay, we have 10 minutes, a little less. Okay. And I will repeat your question so we can get it on the tape. Okay, so 2 questions. The first one is about screening instruments that are appropriate in the Latina community. And the second one is about less intensive programs, because our diplomados are 6-month programs. So are there less intensive ways to raise awareness in churches and congregations? Some examples. So anybody?
So one of the things that I mentioned is the importance of inviting mental health providers to do talks at churches. Because one thing that it sparked my mind when I was hearing Leo speak is very often as clinicians, we think, oh, I understand mental health. I'm going to promote mental health by doing counseling. And this is a good approach, but it doesn't fully address the issue. When we empower pastors who are in the front lines, and they are often the first people that are sought when people are struggling, we are doing an intervention that has exponential impact. So one of the ways that we can maybe bridge this is by inviting mental health professionals to our congregations to train the leaders and the pastors on basic skills. And one of the things that I was thinking, Leo tapped into the burnout. A great deal of burnout happens because pastors do not understand what is outside the scope of their training and capacity. And just giving them those tools so they know when to refer, helping them put together a list of resources so they can, when somebody comes to them struggling, they can triage and then say, okay, Grace community is going to help with this because this person needs financial support. And my role as a pastor is to provide pastoral guidance. I cannot do counseling. The counselor cannot be a pastor. I'm going to focus in doing the role that I'm called to do. And then that it's outside of my training, I can refer out. So to answer the question in a short form, it would be inviting people to speak and do short trainings at churches or community-based counseling centers. Can also invite pastors on speaking about what the church is doing. My church is partnering right now with the city in creating those connections. And when somebody comes to the church struggling mentally, then the church has places that they can refer them for those services. So there are ways, shorter ways, but probably that require the initiative of maybe a group of pastors getting together and putting something smaller at one of the churches or rotating to make that happen. I'm not sure if Fuller has something shorter, but these are just ways that we can start bridging that gap.
I am going back and forth. We have questions online as well. So I wondered, though, Sylvia, about screening, if you have some suggestions around screening. I think it's the other one that works, the yellow one, yeah.
Hello? Yeah. So most screeners are that people use, not just doctors, but even mental health providers, are actually just translated. So they are not very helpful, obviously. I think probably one of the most helpful screeners that I have found is the ACEs one, which almost all medical providers are actually using now. And that is really just to see if people, meet a certain criteria that, it's asking you about, like, have you been abused? Have you been in a domestic violence situation or things like that? It's rating you to see, and the doctor or the provider can see, like, oh, this person could benefit from mental health services. So that's one of the ones that I think is the most effective, honestly, to use. The other ones, not so much. And I did want to comment on what Marisol said. Since I've been the director of training for Fuller Psychological Family Service in the past year, I have been receiving a lot of calls from local pastors who are asking for help. And actually one of them asked me to speak to his congregation about burnout. So that is happening, and they are acknowledging that this is helpful and useful. So I just wanted to say that.
So we will make the contact information of our presenters available, because we only have time, I think, for one more question, and it's an online question. So, I'm sorry. We were trying to respect time. So this says, question for the outstanding panelists: what specific interventions are available to help Latinas living in the U.S. aged 11 through 13 whose suicide attempt is close to 30%? From an epidemiological perspective, this really stands out as a mental health crisis that also appears to be driven by anxiety and immigration related. What can the church do to help this group of young women who are suffering? Just thought that was an important question. Latinas, a high incidence right now among young Latinas of suicide. Any response to that? Yeah.
Is it working? Okay.
Yeah.
I actually, in my work, I have seen the prevalence of that, and it is very high among our population. And the sad thing is that a lot of the work has to be done with the family. Okay, we have to provide education to the parents, because a lot of the times the parents are just like, they're just saying these things, they're fine, or they're not really depressed, they're just being lazy. And so there are these assumptions, right, that they're not really taking this seriously until something bad happens. And it's to the point where they're hospitalized. And even then, there's a lot of denial going on. As far as how the church can help, maybe Marisol can speak to that, but it is hard to talk to parents about this, because obviously they don't want to see their child in distress, and they also see this as a reflection of themselves and being, a parent.
I can speak from the perspective of what the church can do. One of the things that I admire about the student ministry at my church is that we have about 300 kids that are part of the youth ministry. But anyone that it's committed to come frequently, it's assigned to a small group. And each small group, ranging between 8 to 10 teenagers, have a facilitator assigned. And they meet during the main service to process things of these natures. And then their facilitators have been trained. So when they are struggling, they will request the permission of this teenager to say, is it okay if I speak with your parents and I connect you with a counselor? This is at the church. And then when thinking about what we as clinicians can do with this suicide crisis, I want to speak from a case that I am currently working with. And this is a 15-year-old Latina that had attempted suicide and was hospitalized. And when discharged, she came to me for services. And she was failing almost every single class at school. And one of the things that she said is, I've learned that I'm Latina. In the school that I am, if you're Latino, you are with the ones that smoke weed. You are with the ones that are failing classes, because you learn that that's where you fit. So for her idea of herself was tied up to her status as Latina. And it was very helpful for her to explore in therapy other ways of seeing herself and how those ties to her Latino heritage. And just to give you the summary, she's now thriving. She's taking mostly AP classes. She's thriving academically because she has realized that being Latina doesn't mean that she has to be in the category of the students that are failing and smoking weed, that she can be one of those students that thrive. And now she's taking pride in that she is dreaming. Before, she didn't dream of going to college. Now she's dreaming of going to college and being the first in her family obtaining a college degree. It takes a counselor that can sit and say, this being Latina doesn't mean this. This is the category where you can aspire to be.
Amen. Alleluia. We're going to stop. We will make the PowerPoints available to anybody who's interested, and also information about our diplomado so that you can find it on Centro Latino.